Hey friends, welcome to another Transforming Chaplaincy webinar. I'm so glad that you are here among us today. I think you're in for a treat. So if you've not been with us before, I just go through a few slides here as we move forward in this process. So we're very excited that you've decided to join us today. If you're joining us on YouTube, thanks for taking some time, even if you ramp up the speed to time and a half. Thanks for being a part of this. So welcome to Spiritual Care in Public Mental Health Hospitals. We have a couple of webinars coming up in December that I want to mention to you. We're a little biased because actually I'm kind of biased because I got to work on this project, but Chaba Salaji is the director of Transforming Chaplaincy, and Kristen Langstrad was a part of our project as well. Both of these folks are ACP educators, and we're very glad to be hosting this webinar as we are today with our friends with the ACPE. So if you don't have a smartphone, stay tuned to the channels that Transforming Chaplaincy gets the word out, and we're glad to have you join us for that event. And then a week later, we're also going to be hosting an event that was actually it already happened in some ways. Back in June, if you joined us at the Association of Professional Chaplains Conference, Dr. Martin Walton from the Netherlands gave a fantastic plenary, and so he's kindly going to be doing that for us again. So sort of a gift for the holidays. So if you can join us, we would love to see you for that. And as you can probably see, it goes a little bit longer than usual. We don't want to miss out on that opportunity. And then oh, go ahead. Okay. We have another Transforming Chaplaincy Research Literacy 101 course coming up. So if you ever wonder about what's the evidence behind a spiritual assessment, or what intervention might be best, and how strong that evidence might be, you can look no further. We'd love to have you join us on learning how to locate, evaluate, and summarize relevant data to your work. So it's my pleasure to introduce you to David Carnish, representing our friends at ACPE. David himself is a board-certified chaplain and an ACPE educator, serving as the director of education for that organization. David is an ordained Baptist minister endorsed by the Alliance of Baptists. He also has a degree in interdisciplinary humanities from Penn State at Harrisburg, and is a PhD student. I feel your pain, David, in that sense, in art history at Temple University. David, take it from here, if you would. Was it coming through, David? Or
there we go. Am I in?
Yeah, here, yeah.
I lost the screen.
I'm coming right back to it.
All right, thank you.
Yeah.
Thanks. Good afternoon, everyone. Welcome. Glad you could join us today for this topic. This is a topic today that's near and dear to my heart. In 1994, I was a chaplain CPE resident at Baptist Hospital in Columbia, South Carolina, where I had the pleasure and privilege of serving in mental health as a chaplaincy student. So I am looking forward to this conversation today. Allow me to introduce to you our two presenters. So Reverend Dr. Lauri Swann is the Director of Chaplaincy Services and is a board certified chaplain and ACPE certified educator at St. Elizabeth's Hospital in Washington, D.C. She's the first African-American woman to hold this position. She has worked for 9 years in psychiatric chaplaincy. She is a thought leader in justice-centered chaplaincy approaches. Within our community of the Association of Clinical Pastoral Education, Dr. Swann serves on the Professional Wellbeing Committee and is the founding member and the convener of the Womanist Approach to Care and Curriculum Community of Practice. And in 2025, she was the recipient of the Transforming Chaplaincy Spiritual Care Management and Leadership Certificate. And then allow me to also introduce to you Dr. Fisher. Dr. Kayla Fisher is a diplomate in the American Board of Psychiatry and Neurology in Psychiatry, Child and Adolescent Psychiatry, and Forensic Psychiatry, a clinical professor of psychiatry at the University of California, Riverside. Dr. Fisher has over 20 years as a psychiatrist and medical director in state hospital systems. Dr. Fisher has served as the chair of the Forensic Hospital Services Committee for the American Academy of Psychiatry and Law, and serves on the executive committee of the American Psychiatry Association Caucus on Religion and Spirituality. I welcome both of you, and we look forward to hearing what you have to say to us and keep us in this conversation that's vital for this time that we're living in.
Right. So, again, let me know.
Looks great, Lauri.
Oops. Not on my end. Goodness. Hold on 1 second. Apologize. Hold on 1 second. Stop sharing again. All right. Okay, let's try you. All right, how do we look?
Fabulous.
Slides only? All right, and now I just need to. All right, all is well? Okay, I just told Paul before we began, I said, I have no problems working with serial killers, but technology intimidates me. So I'm grateful for this, that we're right where we need to be. So before I began, I just want to thank Dr. Fischette for the opportunity to share this work and for the ongoing leadership in advancing research on spiritual care and mental health. My own context for this project, as noted, I am at St. Elizabeth's Hospital, and I've been here for 9 years. St. Elizabeth's, which is in Washington, D.C., is a historic public psychiatric institution that has shaped both the story of mental health care and the evolution of chaplaincy in the United States. St. Elizabeth's was the first federally funded hospital in the United States, and at that time, it was formed in 1855. And at that time, we were able to care for about 7,000 to 8,000 patients at its peak. And currently, we cared for about 277 to 300. So the work that follows lies, in my opinion, at the intersection of history, policy, and lived experience. So to understand the realities facing chaplains in today's public psychiatric systems, we first must look at how the state hospital evolved and what was lost through a term called deinstitutionalization, which I'll talk about in a few minutes. So this study really grew out of a question I found myself wrestling with during my Transforming Chaplaincy, Spiritual Care and Management and Leadership course, which was how do I make sure spiritual care remains equitable, clinically integrated, and ethically sound in systems that are chronically underfunded and understaffed. So with that context, there are 3 things that I want to clarify up front. First of all, what do we mean when we talk about a state hospital? And what do we mean by serious and persistent mental illness or the serious and persistent mentally ill? And then I want to lay down one major historical fact that shaped everything we see in public psychiatry today or psychiatric care today, which is deinstitutionalization. And I'm going to say, there's so much information, so it'll appear that I'm talking really fast, but I'm trying to get so much in within the 30, 35 minutes that I have. So first, what is a state hospital? So there are publicly funded institutions that care for people living with the most serious and persistent mentally ill. Many of these are under court or civil commitment, meaning their stay isn't voluntary. These hospitals have long-term treatment environments, and too often chaplaincy in these spaces is missing part-time or missing chaplains, or the chaplains out of there are part-time or were just severely underfunded. So in regards to funding, state psychiatric hospitals are financed primarily through state general funds and Medicaid reimbursements, but chaplaincy is rarely reimbursable under Medicaid or private insurance because spiritual care is considered non-billable and not considered a clinical position that generates reimbursements. So by contrast, community hospitals focus on short-term crisis stabilization. Private hospitals serve those with insurance or the means to self-pay, and faith-based hospitals, while often rich in spiritual programming, are few and limited in reach. So when we talk about spiritual care inequity, this is the clearest example. where those with the highest needs have the least access to chaplains. By definition, where those with the highest needs have the least access to chaplains. So what do I mean by that? Patients with serious and persistent mental illnesses often are under long-term treatment, long-term hospitalization, civil commitment, or forensic commitment. And I'll talk about that in a second. So the experience of the most severe forms of suffering, freedom, family separation is seen through this community, stigma, right? And existential distress. So spiritually, these are the very conditions that call for sustained pastoral presence. Yet paradoxically, the public state psychiatric hospital employs the fewest chaplains per capita of any hospital type in the United States. State hospitals primarily serve two groups: forensic patients, those whose care is court ordered after being found incompetent to stand trial or not guilty by reason of insanity. And then the civilly committed patients, and those are those whose illnesses makes them a danger to themselves or others, or unable to safely care for themselves. So both groups live under legal oversight and restrictions. So now real quickly, let's define the setting that clarifies this population served. So we hear about mental health all the time, right? Mental health refers to that broad spectrum. Everyone has it, just like physical health. It includes emotional, psychological, and social well-being, and so on. Not everybody has a mental illness. Not everybody has a severe and persistent mental illness. So when we talk about SPMI, severe and persistent mental illness, and sometimes that severe can also be translated to serious, these are chronic severe psychiatric disorders such as schizophrenia, bipolar disorder, major depression with psychotic features. They profoundly impact daily functioning and often require long-term commitment, as I shared, or inpatient care. Most state hospitals fall into this category because people living with SPMI often experience symptoms that can impair judgment, insight, and behavior. And when those symptoms go untreated, or when systems fail to provide consistent care and housing, individuals may end up in crisis. And that draws attention to law enforcement and emergency services. So while mental health is broad, SPMI is very significant in terms of detail, particularly when we're talking about the severity of it. So the state hospitals precisely have this type of population, and they are designed to serve often with under-resourced employment, clinical assistance, and spiritual care. So to understand why spiritual care looks the way it does, I'd like to transition into a little bit of history before we get into deinstitutionalization. So the story of state hospitals and the story of state hospital chaplaincy is cyclical. It went from isolation to brief connection, and from recognition to somewhat where we are now, which is a return to fragmentation and scarcity. So nearly 80 years ago, state hospitals and mental health chaplains were isolated islands. In 1947, Ernest Bruder of St. Elizabeth's, my predecessor, and J. Obert Kempson of South Carolina State Hospital met in DC to discuss the isolation of mental health chaplains in psychiatric settings. And so in the same year, a special session at the annual conference of chaplain supervisors led to the idea of forming an organization for chaplains in mental hospitals. And so a questionnaire went out and 26 chaplains responded. And on May 18th, 1948, there was the foundation of the Association of Mental Health Hospital Chaplains. And they were created to provide fellowship, education, and mutual support. So as care shifted from institutions to communities, AMHC evolved, eventually merging in 1998 with the College of Chaplains to form what is today known as the Association of Professional Chaplains. And so this history reminds us that mental health chaplaincy was born out of isolation, inequity, and the conviction that spiritual care is central to healing. So to fully grasp today's challenges, we must return to a defining moment in American mental health history, and that is deinstitutionalization. So beginning in the mid 1950s, thereabout, the nation moved to close large psychiatric hospitals and shift treatment into community settings. So on paper, it sounded like progress, right? Care in less restrictive environments, closer to home. But in practice, community systems were never adequately funded, leading to the slow unraveling of the state hospital systems. Beds disappeared, staff were cut, and chaplaincy positions were among the first to go. So the result is the system that we see today, stretched thin, under-resourced, and often unable to meet the spiritual or human needs of those it serves. And historically, President John F. Kennedy's Community Mental Health Act of 1963 promised 1,500 community mental health centers across the country, envisioning compassionate regional hubs for care and reintegration, yet less than half were ever built before responsibility shifted to the states. And then later, policy changes under Ronald Reagan from the Lanterman-Petraeus Short Act in 1967 to the Omnibus Budget Reconciliation Act of 1981 further dismantled oversight and redirected funds away from psychiatric care. So the impact was devastating, right? State hospitals closed in mass, yet the promised community infrastructure never fully marginalized. So individuals with SPMI were left cycling between homelessness, emergency rooms, and incarceration, and is still the case today. So chaplains now serve in the shadow of that policy legacy, ministering to overburdened, underfunded, and often forgotten facilities. And so real quickly for St. Elizabeth's, being that we were the first federally funded hospital, I just wanted to reference how we became part of the District of Columbia. So in 1983, through the U.S. Department of Health and Human Services, they were seeking to reduce its role in operating the hospital. So St. Elizabeth's role would be narrowed to long-term inpatient care, rehabilitative psychiatric care, psychiatric nursing, forensic psychiatry, and specialized programs. And acute psychiatric care was shifted to general hospitals, which would also allow for greater Medicaid reimbursement. So what happened for us? Staffing at St. Elizabeth's would change significantly. The inpatient census at St. Elizabeth would drop significantly, hence the 277 to 300 number that I quoted earlier. And there was a significant outplacing. So what does that mean theologically? I got to bring that in as a spiritual care practitioner. Deinstitutionalization reveals a moral paradox, right? It represents our collective failure to balance autonomy with responsibility. So for spiritual care providers, the task is not only to serve within these systems, but to advocate for transformation, restoring care and dignity to the people they were meant to heal. So this is where the study begins. Listening to chaplains who continue to serve within these conditions of scarcity, yet with resilience. But before I move on, what's the spiritual care implication of all this? Well, with the institutionalization comes spiritual care implications. So although federal mandates such as the Religious Freedom Restoration Act and the Centers for Medicare and Medicaid Services conditions of participation affirm the right to spiritual care, compliance is often nominal. So for those state hospitals still functioning, resources are at a bare minimum. So for some, chapels are shuttered, worship services and worship spaces are repurposed, and multi-faith staffing, it's frozen under budget austerity. And so for chaplains, the ethical imperative becomes restructuring sacred space within secular systems. So the research question then is not only about providing spiritual care within these restrictions, but how justice-oriented chaplaincy can persist when eroded with institutional ecologies. So just a little bit about me and how I even got to this place, this question and this research. One day I was driving into the gates of St. Elizabeth's Hospital, and I noticed people walking their dogs and getting children to the bus stop and enjoying the newly refurbished apartments that's on the campus of St. Elizabeth's now. And I just had this visceral experience real quick. because probably a day or two prior, I just had a conversation about my lack of resources, and I didn't have any Bibles. And unlike many departments, I don't have a budget to even refurbish when I run out. I have to, wait until there's money available. And while I'm watching all this growth outside, back at the ranch, if you will, my department, I'm struggling. I'm refurbishing stained altar cloths for Sunday services. I'm implementing a need-only resource restriction for religious materials due to shortage. And I'm grieved over the realization that what was once a thriving hospital community, including spiritual resources, had been eroded by deinstitutionalization. And so this reflection brought me full circle to the origins of psychiatric chaplaincy. And historically, state hospitals like St. Elizabeth's was primary training ground for pastoral care. So I want to direct your attention to this picture. This is St. Elizabeth's Hospital. Back in 1957, the person at the edge of the table is Anton Boysen. And to our left, I believe, is Ernest Bruder, who is my predecessor. And this is one of his final lectures. I call Anton Boysen the friend of St. Elizabeth's Hospital. And if you can see, there's probably about 12 CPE residents around the table, and back on the wall are former classes of CPE residents learning about mental health and psychiatric care. Today I have 3 residents, and we don't have a budget for more at this stage. And it seems as though the hospitals itself, we're just isolated in our various worlds, and we're not connecting, and we're struggling. And so gone are the days of the 1957 years of Boysen and St. Elizabeth's. And so here I am thinking like Kempson and Bruder, wondering how can I do my job to the best of my ability with the resources I have, but for a population that I love deeply. And so I struggled, and I am grateful that through Transforming Chaplaincy, I was able to raise the question as a part of reflection. And that's when Dr. Fischette reached out and asked, is this something that I would like to pursue? And I'm so grateful for the opportunity, because I wanted to know, how do we provide equity? How do we provide access? How do we provide these resources? And like Kempson, is there anybody else out there that's struggling? And if so, can we come together? Can we develop advocacy? Maybe even legislation? What can we do? So we developed the IRB, and we started with a review of the literature, and empirical scholarship consistently demonstrates the salutary relationship between religiosity and spirituality and mental health outcomes. Yet research specifically addressing spirituality among persons with serious and persistent mental illnesses, it remains sparse. So Corrigan and others highlight that spirituality can enhance meaning making, coping, and recovery, but institutional chaplaincy resources have not matched this evidence. And so the gap substantiates the study's significance to extend the literature beyond correlational findings toward structural analysis, meaning how institutional neglect undermines spiritual informed recovery for marginalized psychiatric populations. And so just as a summary for this slide, research shows that spirituality correlates with better mental health outcomes, but few studies focus on serious mental illness, especially those in the forensic and civil populations. So the study itself, we engaged 5 chaplains serving in public psychiatric hospitals or nonprofit behavioral health organizations. One was part of a nonprofit behavioral health organization across the United States. All of them work in settings where care is shaped by both clinical and legal structure environments, and which means where individuals with serious and persistent mental illnesses are either civilly or forensically committed. Participants were recruited through the Transforming Chaplaincy Mental Health Network and through snowball sampling, meaning participants were referred to us by colleagues working in similar systems. Each chaplain participated in a semi-structured interview lasting for about an hour. Interviews were audio recorded, transcribed, and verified to ensure accuracy. And then we used a thematic analysis approach, moving systematically from the raw transcript to codes, categories, and emerging themes. And so this process allows us to identify shared experiences, particularly around access, equity, and the spiritual implications of working in under-resourced psychiatric environments. So in short, these methods grounded the project in lived experience of practitioners, allowing their voices to shape how we understand spiritual care and equities in state hospitals. So our key interview themes, these are the few that emerged across each participant. So first, resource limitations. Chaplains spoke about being the only spiritual care provider for hundreds of patients, often without backup or designated space for worship. They described moments of deep fatigue, not because of the patients themselves, but because of the system's chronic neglect of spiritual life. And then second, institutional barriers surface at every level: funding restrictions, administrative indifference, and sometimes clinical misunderstanding of what chaplains actually do. And then third, chaplains reflected on the perceived efficacy of spiritual care, the quiet, often invisible work of humanizing treatment, right? They noted that while administrators may not measure it, patients consistently describe chaplaincy as the space of hope and stability in an otherwise chaotic environment. And then finally, for this particular slide, recommendations for reform emerged organically. Participants called for increased staffing, spiritual care integration within treatment teams, and training that equips clinicians to recognize spiritual distress. And so our participant characteristics, a very small but deeply experienced group of chaplains who I am so proud to call my colleagues and cohort. They all go beyond the call of duty for the patients that they serve. All participants were board certified or equivalently trained, and most had over a decade of experience in mental health or forensic settings. Several had dual roles, balancing clinical chaplaincy, supervision, and sometimes administrative or teaching responsibilities. Demographically, the group reflected diversity in race and gender and denominational background, which shaped how each person understood their ministry. One African-American chaplain spoke about how their visibility within state institutions carried its own pastoral significance, embodying representation in spaces where many patients rarely see leadership that looks like them. How we conducted the analysis of interviews. So this project used thematic analysis to find patterns in the chaplain's interview. We began by identifying the common ideas like limited resources, institutional barriers, and the effectiveness of spiritual care. And then these ideas were refined into broader themes and sub-themes that reveal both the challenges and the creative ways chaplains respond. And I'm smiling at this because this is where I had the most fun with George, because we would literally look at the data and we'd try and pull out the themes, and he's literally looking at what is said and creating a theme and sub-theme. And here I am adding in my 2 cents. He's like, but I didn't see that in the transcript. I said, yeah, well, what they really meant was, so I'm grateful for him reeling me back in and for his patience. But so this approach centers the voice of practitioners, right? Recognizing their lived experience as primary sources of knowledge. The goal wasn't just to describe any inequity, but to turn their stories into insight that can guide advocacy and meaningful change in public psychiatric systems. So the themes, and there were some other themes that I wanted to look at, particularly for the state hospital, which we didn't get a chance to gather that much data, which was restraint and seclusion, safety, some other things. So hopefully, as we move forward, that will come back to surface. But nevertheless, so the first theme that came up was the chaplain's view of their role. And regarding the sub-theme for role, chaplains view themselves as mediators between clinical language and spiritual meaning, translating suffering into hope while negotiating boundaries with interdisciplinary teams, right? So their accounts reveal tension between being clinically accountable and what I define as prophetically present, meaning bearing witness and advocating and speaking truth to settings where human dignity is often threatened or forgotten. So advocacy being another theme emerged as a defining feature of identity. Chaplains spoke of writing policy memos, negotiating sacred space access, and confronting inequitable practices. They understood advocacy not as optional, but as an intrinsic spiritual, intrinsic to spiritual care. And before I move on, I want to point your attention to the quote for advocacy, which I just love. He says, I'm working directly with the staff who is here to make sure that our clients have equitable, fair legal treatment that they're supposed to have. So you can't deny them this. So for example, you can't deny a patient glasses because you're worried they'll eat them. They need to be able to see. So those are the things that these chaplains have to balance on a daily basis, providing voice to the folks that we serve. Regarding racism and representation, some recognize their visibility, as I already noted, as being very powerful and modeling possibility for other patients. In regards to chaplains, their feelings about their work, all of them loved what they did, loved their job. One person described his work as every day deciding what is the garden within his reach. And that's such a beautiful phrase that we loved, meaning as one person, I have to decide, what am I going to do today? Am I going to do a one-to-one? Am I going to go to an interdisciplinary team meeting? Am I going to do my spirituality groups? But because of the staffing, I have to decide. But all of it is a garden. All of it is beautiful, and all of it needs to be tended to. More themes. So this slide highlights the everyday realities of chaplains. And I have 5 minutes. Work in the state psychiatric hospitals. Much of their time is devoted to core spiritual care functions, leading worship, running groups, coordinating care for patients from diverse faith traditions. One chaplain described their workload vividly as having 3 people full-time for 96 patients is still a heavy load. When it's just me, I can only manage about 6 one-to-ones a week on top of groups and admin. Beyond patient care, chaplains also play a crucial role on interdisciplinary teams and provide emotional and spiritual support to staff. But training and preparedness vary widely. As one chaplain noted, she said, I won't look at anybody who doesn't have 4 units of CPE. Mental health requires depth, stability, and experience. And I completely agree with this statement. But the problem that we face in this the problem that we face overall is that we do not have enough CPE programs that are specific to behavioral health, mental health, or severe and persistent mental illness. So right now, I think we can count 3, and I'm going to say 3.5 because one of the individuals that we've interviewed is in the process of being certified, and hopefully he will be able to open up and teach more in his hospital. But we need more. So that we can have the training, and I'll discuss that in brief in a second. Participants repeatedly identified staff shortages as the single greatest detriment of inequitable spiritual care access. Most facilities function with one full-time chaplain responsible for several hundred patients, which is a ratio far exceeding standards recommended by the Association of Professional Chaplains. And the deficit results not from disinterest, but from chronic underfunding with state systems. In the face of scarcity, chaplains often depend on volunteers, retired clergy, or seminary interns. While volunteers expand capacity, they introduce inconsistency, and they raise questions about training and confidentiality and theological alignment. Because for us, we have to be very careful of who we're bringing in, because we need to make sure that whether it's a volunteer or just someone who maybe even an intern that decides to want to do a residency, that they don't have a hidden agenda, which is, I want to cast out the demonic of the mentally ill, or I want to proselytize because they're sinners as a result of what they've done, which is true experience. So we have to be very mindful in this field of what we're doing and who we're bringing into this population to care. So regarding resources, participants describe limited access to sacred texts, ritual items, and worship space. Gideon Bibles, we love the Gideons because we all cited as among the few who were able to provide material consistently to these hospitals, mine included. But this signals reliance on external philanthropy rather than institutional investment. So the theological implication is stark spiritual life, right, in public psychiatry, because we're surviving through charity and not infrastructure. So when asked about how they obtain needed materials for support, chaplains describe the system dependent on improvisation and advocacy rather than predictable funding streams. Many relied on personal networks, community partnerships, or donations to acquire ritual items, prayer books, or communion supplies. This scavenger ethic, which is what I refer to it as, underscores the moral labor required simply to maintain baseline presence. And I would like to draw your attention to the quote above where it says how you get things needed. This person said, I have a monthly contribution fund, then I give to the resources here. If not, I give it to my church. So he is paying out of pocket for the things that he needs, just to make sure that his folks are cared for. And that is somewhat a theme that that ran across the board, which transitions me to lack of institutional resources, which was nearly universal. Some chaplains succeeded in securing small grants or administrative goodwill, yet these were exceptions, not norms. Importantly, participants noted that metrics and documentation, such as visit counts or satisfaction surveys, did not translate into greater institutional support. And this disjunction reveals what Michael Power calls the audit paradox, right? Measurement without measuring, without meaning. So while chaplains increasingly generate quantitative data to demonstrate value, administrators remain unmoved without corresponding policy mandates. And so this finding points to the need for research translation, moving from descriptive metrics to outcome-based evidence that can inform funding decisions and legislative advocacy. So nearly every participant emphasized the shortage of spiritual care staff, as I noted, and its direct impact on the scope of services offered. Several chaplains expressed faith in research as a pathway to reform, believing that empirical evidence linked spiritual care to patient outcomes, and with the hope that this could possibly persuade administrators to expand staffing. However, participants argue that evidence alone is insufficient without education. They called for structured training for both hospital leadership and clinical staff to clarify what chaplains do and why it matters. And then one last slide regarding our sub-themes before we move to the challenges. And I know that I'm at 30 minutes. Participants emphasized the need to equip therapists and clinical staff in spiritually integrated care. Approaches that honor patients' faith frameworks within ethical and therapeutic boundaries. Chaplains describe their evolving role as educators and collaborators, bringing theological literacy and cultural insight that enrich clinical understanding. Through interdisciplinary seminars and joint case consultations, they envisioned a model where spirituality is no longer peripheral, but woven into the treatment itself. So finally, and real quick, our challenges. So this slide grounds our qualitative findings in the structural realities of American mental health care. Participants consistently described state psychiatric hospitals as repositories for the unattended, individuals whose illness, poverty, or criminalization placed them outside community-based systems. As one chaplain put it, these are the places where society puts where people it doesn't want to attend to. They emphasize that institutional neglect is both material and moral, chronic underfunding, decaying infrastructure, and limited staffing signal not only policy failure, but a failure of collective empathy. So patients in these settings are often doubly marginalized, right? Disproportionately poor, racialized, and without meaningful social support. So this starkly reveals how privilege shapes access to mental health treatment, who receives timely care in community settings versus who cycles through jail, through court, or long-term confinement. This slide highlights the wait list, bringing your attention to the second bar where the individual said, we don't have enough space here. You have 58 people waiting. One of those people is a woman who was discharged. She's sitting in jail right now. Most of them are in jail while they wait here. And I'd like to draw your attention down to the bottom, the last quote where the person says, the reason they're still here is your forensic department here is very risk averse and they won't move people forward. The reason they're still here is you've stopped passes in the state and you can't evaluate people's readiness. The reason they're still here is there's nowhere next for them to go. And the reason they're here is the country refuses to accept them back. That is such a profound statement. And so the waitlist crisis really captures the heartbreak of the whole system because our public hospitals don't have enough beds. People who've been found incompetent to stand trial often sit in jail for months before they ever see treatment. And during that time, their condition gets worse, they decompensate, they lose hope, and the cycle of incarceration just deepens. So forensic and civilly incarcerated patients often experience what I name spiritual dislocation, right? Guilt, shame, moral injury, and loss of identity. And so chaplains are needed because we are there to provide that trauma-informed, spiritually integrated care. We're there to help the patients reframe suffering and restore the agency and rediscover dignity, even within confinement. But without these chaplains, this dimension of healing is completely absent, leaving a vacuum. So as I'm concluding, I just wanted to recognize one more challenge, which is the funding mechanisms, which further exacerbate inequity. Chaplains cited instances where patients lost Medicaid coverage without notification, were billed for services or accrued debt while still institutionalized. And such administrative neglect transforms illness into chronic economic punishment, right? Contradicting the intent of public health policy. And so, in summary, our discussion, this study revealed that the crisis in spiritual care within public state psychiatric hospitals is not simply a staffing problem. It is a moral barometer of how society values persons living with serious and persistent mental illnesses. The data shows that systemic neglect, bureaucratic inertia, and punitive culture converge to produce what can only be called spiritual inequity. The unequal capacity of patients to encounter meaning and hope and sacred presence within their treatment. And at the empirical level, themes of understaffing, lack of resources, and administrative delay confirm a national trend toward the medical industrial marginalization of pastoral care. So chaplains function as both clinicians and conscience sustaining human dignity and amid institutional scarcity. So theologically, these findings demand a reorientation of mental health systems towards relational justice. So ultimately, the pilot study calls for conversion, institutional, ethical, and theological, inviting hospitals and policymakers and faith communities to recognize that access to spiritual care is a matter of justice and not charity. Our study limitations, real quick, as I shared, we were only able to interview 5 people. And even of those 3, I would reference a situation and they would say, oh, that's where the state hospital comes in. And that's who we're looking for. We're still looking for the folks in the state hospitals. This is just a sampling, but from this outreach, we need to look more at the study, looking at the broader systemic issues, the research, how do we capture national patterns and gaps? And so with that said, the next step is to widen the lens and the scope to transform qualitative insights and actionable advocacy. And then finally, with advocacy, we need to have perhaps a national team, something that we can do to move forward, especially to promote more CPE programs in our hospitals so that we can get folks trained and so that we can get the chaplains out there to be able to care for this beloved community. And then finally, the research. There's more to come because, as I said, there's simply not enough evidence-based research within the state hospital and the forensic population in the context of spiritual care, and much more is needed as we continue to argue the necessity of increased spiritual care and access in these institutions. So I thank you. I'm going to now turn it over to Kayla, and I'm going to stop sharing.
All right, thank you so much. And I'm going to share with you, I've been a medical director in multiple state hospital systems, specifically Virginia, Tennessee, and then also treated patients in the Ohio system and served as a medical director in the California state hospital system. I'm going to share with you a little bit of just the personal experience of working with chaplains in one particular hospital where I found it very meaningful. I did put a few notes on slides that I might just share here if I can quickly. Let's see if it allows me to. Nope. That's not right, sorry. Well, it may not let me. Can try again. It's not. Okay, so I'll just go with the notes that I made, but just thought that it might be nice to see a visual. But I wanted to talk with you about a little bit of my experience of working with chaplains and what I found to be super helpful in treatment. And that was the concept of using the chaplains on the treatment team. Now, not all systems do it this way. Sometimes the chaplains see patients, they have their allotment or a different system of seeing patients, but my experience where I found the chaplains most helpful in the treatment was when I actually invited them to sit on the treatment team. For those of you who may not be in state hospitals, it's a collection of clinicians that sit together, and we sat together every day. We talked about the updates in the treatment, what was happening with each person, etc. in their treatment, what had transpired, often revolving around things like whether someone's medication compliant, behavioral issues with that person, and how we were going to move that person forward. So I invited the chaplains to meet every day with the treatment team, and they weren't able to do it every day, but many days they were. We found that to be highly effective because they knew really from even a clinician's lens what was going on with these individuals. You know, we have a lot of patients on state psychiatric hospitals, as has been presented. And as the beds have decreased and we've tried to move people more into the community for community-based treatment, and like was presented, it sounds like a great idea. Why should we put someone in a hospital if they can be treated in the community? Well, that's a whole other presentation perhaps on that whole debate. But what the result has been is that the people that are in the hospitals are much more acute and ill. They are really in need. So any of those that might have a hint of being able to be treated in the community are now moved out. And what we have left on our state hospitals are people who are very ill with lots of psychological and psychiatric problems. What I found is by using the chaplains that they were able to provide really clinically important feedback on many patients, because the patients did not view them as maybe part of the opposition, if you will, in people who are trying to give them treatment. Because one thing that happens with patients who are psychotic, oftentimes they're not raising their hand saying, I have psychosis and I'm ready for treatment. Rather, it's a denial of the illness and a belief that, you know, the rest of the world is amiss, but they are fine. But they would be willing to meet with the chaplain, even though they were not, you know, wouldn't be welcoming a meeting with the treatment nurse or anybody else who was part of more their medication management, or certainly not their doctor. So I found that the chaplains were very key in providing feedback because they were accepted by most patients as being a welcome party, and they would learn things about the patients that we weren't always able to tap into through any other method. Also, by having the chaplains on the treatment team and talking with the chaplains, you know, daily, we were able to let them know which patients had the most need from our lens, at least as clinicians, and which ones would perhaps benefit most from their visits. And so we did make specific requests of the chaplains to help them prioritize their limited time. I knew that the chaplains were able to, as been discussed, provide Bibles to the patients, and many of them, this is very meaningful. Now, they may not do much Bible reading outside the hospital. That has wide variability. But in their time of need and when they are being in a hospital, often and usually against their will, being provided a Bible was highly meaningful. The chaplains also offered prayer with patients. The patients would refer to it and talk about it and how meaningful that was to them in helping them feel cared for in their time of treatment. They would discuss spiritual topics with the patients. One of the things that happens with psychosis, and I teach this to all the young doctors that I am training, is that when someone becomes psychotic, there's a few topics that typically are manifested in the psychosis, and they are tend to be power, sexual topics, and religion. And so sometimes just having the chaplain there to help guide them in their to what's reality based in what their religious beliefs are was very helpful. And that so the chaplain would do that with many patients. What I observed through this process of using the chaplains is I observed multiple things that were of benefit. One is that it helped address the patient's spiritual distress. Some of them in their delusional belief believed that God was punishing them or that they were being tormented in some way. And they found the visits from the chaplain to be very helpful in alleviating that distress. They also found that they experienced emotional support from the chaplains. They tended to very much welcome the chaplain visits. In fact, the chaplain's time was in high demand. The chaplains would often assist with grief issues with patients in a very meaningful way because they were able to combine not just the grief process, but also combine that with perhaps, depending on the person's faith, but reading scripture or prayer, and patients found that very comforting. They were able to enhance patients' coping mechanisms. They came back to our treatment team meetings and they discussed this, what they had talked with the patients about. And then surprisingly, perhaps to some of you, but is that the chaplain visits were able to increase medication compliance. Again, the patients would often look at me like I was maybe on the being employed by the pharmaceutical company or something, and with a lot of distrust. But meeting with the chaplains really helped to build that trust and helped many patients to be able to accept their need for medication, because some of these illnesses like mania and like psychosis actually worsen the longer that we leave a person in that untreated state. And so the chaplains were very helpful in getting some individuals to agree to medications. We also saw that the chaplains would help patients who were having conflicts. Perhaps it was a conflict with a family member. Perhaps it was a conflict on the unit. And that we really saw improved patient outcomes more quickly when the chaplain was involved. So if I could have increased the chaplain's time on the unit, that would have been a good thing, because so many patients benefited from their visits. They also found that the chaplains would help in their dialogues with patients increase prosocial values. So we found that to be very beneficial. Supporting continuity of care, again, because the patients would often trust the chaplains at a level that was beyond what they were trusting other people on the treatment team, we found that they were able to get patients to agree to perhaps discuss what was going to be the next step when they did discharge. Really helping also ethical resolutions about sometimes when we were going to have to go to forced meds, we sometimes would not have to because the chaplain was able to be instrumental in getting someone to agree to meds. And then just overall enhancing the hope and meaning that people were experiencing. And in my experience, that model of having the chaplain just very much entwined with the treatment team was the best that I found working in the state hospitals, because we are dealing with all the time, with every passing year, it seems like the state hospitals have increasingly sicker and more acute patients. And so doing everything we can to help get people well as quickly as possible and address their needs so they are not so distraught in the treatment process is extremely important. And I am happy to answer any questions that people might have of any of my experiences on the state hospitals and working with people with spiritual needs. It is of course, Joint Commission requirement, as has been presented, that we do assess people's spiritual needs and do provide for them in some measure that has been lacks a lot of specificity, but the more that we can have chaplains, my experience has been the better the patient care overall will be.
Thank you both. Opening up the floor in the chat for questions. If anyone has any questions. I think I would love to hear Dr. Fisher and Dr. Swann, if you would talk about how you might envision chaplains becoming recognized as clinical members. I know individual hospitals sometimes are able to do that, but how we could do that on a larger scale across the United States, I'd love to hear your thoughts on that, if either of you have a thought on that while we're waiting for other questions to populate.
Yeah, I think there's just a couple things. I think, one is that there is a lot of training to become a chaplain. And I think that that's not always known. And I think increasing the awareness among clinicians of that, and that, it isn't just the local pastor coming in, right? It is a specific training and certification, I think, is important to promote, to provide for advocacy. And I think really just finding the most research that we can provide regarding things such as Dr. Swann is doing already, I think is highly important. And, really advocating for, I would say, the model of the chaplain being a part of the treatment team. That means being able to sit in on the meetings and not being separate. They come in and they find out who has an order for a chaplain visit, and that's great. But really being in communication with the clinicians, I found invaluable. So those would be a few thoughts.
Yeah, for me, I'm going to start with just simple education, because as I referenced, 80 years ago, we had a mental health organization, we had a viable community, and now here we are back to trying to explain why we do what we do. And that just doesn't make any sense to me. So when we went into deinstitutionalization, so did the field of psychiatric chaplaincy. And so we need to go back and define, this is who I am. I have a viable part. I am a clinical practitioner. I should be invited into, I am part of the interdisciplinary team. And so we need to somehow, through this research, through more conversations, for more visibility, definitely through more clinical pastoral education programs where we can do Medicare pass-through, and we can get some visibility on, hey, we're billable because this is what we do. We do training, or, we're here. So it begins with the education.
Thank you both. There's some questions here. One is, Dr. Fisher, will your notes be available to those of us that are here today?
Sure.
And then
Yes.
there's one question here. How might outpatient spiritual support through medical centers and clinics look to follow up on patients when they reintegrate into society?
Can you read that again? Is it?
Yeah, how might outpatient spiritual support through medical centers and clinics look to follow up on patients when those patients reintegrate into society? I know we're at time, but that's the last question I have here.
Well, for us, St. Elizabeth, we're trying to develop a tracking program where we can track those that have been discharged for a certain time frame. But I think for each center, there needs to be some creativity to be able to continue to journey with those that have been discharged into community.
Dr. Fisher, would you like, would you want to
Yeah,
respond?
I would just concur that that's super important to have that continuity and for the well-being. I think that certainly that we do that, certainly in the who's going to see you as an outpatient psychiatrist, right? And we need to do that really for a person's spiritual needs too. Where are you going to be connecting when you leave or you are out of even the outpatient clinic? Who are you going to be? Who's the next connection point? Who's the next person that's going to assist you in your spiritual walk? We certainly need to be thinking about that.
Thank you. So friends, thanks for joining us today. David Carnish, our friends at ACPE, so grateful to have done this webinar as well as 2 previous. You can find that on our YouTube channel. Friends, we're going to host another webinar with our friends at ACPE on December 2nd. I dropped the link in there for that. But most of all, thank you, Dr. Fisher. Thank you, Reverend Dr. Swann, for your expertise, for sharing that with us so generously today. Friends, all the best in the work that you do in caring for others and the healing work that we're about. Let's keep advancing spiritual care through research. See you next time. Thank you.